Pelvic girdle pain is a pain around the pelvis area, typically through the pubic symphysis at the front or the sacroiliac joints at the back of the pelvis, and the pain can radiate to the hips or into the thighs. 1/5 of women can experience pelvic girdle pain during their pregnancy, and onset is typically after the second trimester, and it can sustain through the pregnancy and often can reoccur in subsequent pregnancies. So looking at pubic symphysis dysfunction in particular, the symphysis at the front of the pelvis sits about 5 to 6 millimeters gap. In pregnancy, that can increase to 2-3 millimeters. You can get pain through the pubic bone in the groin. It can radiate into the medial thigh. And you get it with movement, single leg movements, such as climbing the stairs, getting in and out the car, moving that leg wide, or just with walking. So while the hormone relaxin is usually associated with joint laxity, in regard to pelvic girdle pain, there's actually no clear correlation between relaxin levels and that joint laxity or pelvic girdle pain. To manage pelvic girdle pain, a lot of it's about activity modification. So it may be reducing step count to less than 3,000, avoiding stairs, avoiding standing on one leg. So, for example, sitting while you dress. Keeping legs together to avoid that hip abduction while getting in and out the car. Using ice, and some people use an ice pack while they're walking, and wearing good footwear. We use the ideas of anatomy slings to help ensure strength across the pelvic region, and also, as this photo demonstrates, using a pelvic belt too can help support the region and decrease pain. 93% of women who are symptomatic with pelvic girdle pain have a resolution of that pain within 3 months postpartum. Tailbone, or also called coccydynia pain, can be common. So that can be a deep ache in the coccyx area, and you may get pain with sitting, pressure on the tailbone, bowel movements with intercourse and climbing stairs. Again, activity modification is the treatment for tailbone. So adjusting the posture, using cushions, and some advice around how they're moving to avoid pain and irritation. Also, there's just using icing, managing constipation, and then some physiotherapy, soft tissue release around the area is effective. About 50% of women will experience lower back pain during pregnancy or in the postpartum period. So that's due to the hormonal changes, the postural changes. It can be the weight of carrying the baby, and the increased breast tissue, and also to do with kind of any psychological kind of stress as well can change our pain, and obviously if there's any injuries during the pregnancy period. So just want to comment that anti-inflammatories are contraindicated in pregnancy, so that's not an option for pain relief. With increased fluid, body fluid, there can be pressure on the nervous system, so you can get carpal tunnel syndrome with wrist pain, where you get pain, burning, pins and needles, and a weak grip strength. So that can affect kind of what exercises that you give pregnant women if they have that issue. We manage that with reducing the force through their tendons by using wrist braces, doing some release and some mobility and strengthening exercises. Another condition that can affect the hand is swelling of the tendons on the thumb side. So this occurs due to repetitive movements of the thumb, and it's called de Quervain's tendinosynovitis. The management includes wrist and thumb splints and modifying movements. Pregnant women can also get something called round ligament pain. So when the uterus grows during pregnancy, there's the round ligaments have to stretch, and there can be put tension on that on those ligaments. So things like sudden movements like sneezing or coughing or rolling over in bed can cause a sudden sharp pain. Movement strategies can help manage it, as well as supporting the abdomen with a pelvic support belt or gentle stretching. The other final topic of musculoskeletal disorders is diastasis rectus abdominis muscle. So this is where the rectus abdominis stretches apart at the position of the linea alba. What is the linea alba? So that's a fibrous band running vertically, and it acts as a muscle anchor for the abdominal muscles with attachments of the oblique and transverse abdominal muscles. Called a DRAM for short. There is a bit of a debate about doing exercise and causing something called coning or doming. And is this a problem, and should we adjust it? But DRAM is not a pathology or an injury. It's something that naturally happens as the baby grows, and it puts pressure on the connective tissue, and so the belly has to accommodate that baby. DRAM is prevalent in 30% of pregnant women at 12 months postpartum. So that's a consideration thinking forward. And there is a concern if women think they've got a DRAM and they're worried about that they'd potentially be avoidant of exercise, which can have recovery effects. So the debate is, should certain exercise or movements be avoided so this DRAM, this doming doesn't happen? But how do we define what a DRAM is? What's that separation that's too much in the rectus abdominis muscle? And is there a relationship of a DRAM between lower back pain, pelvic pain, or pelvic floor dysfunction? And then the abdominal muscles, how important are they in labour? So more recently, there's some better research coming through, and it's definitely challenging our understanding, particularly what our normative measurement is. So DRAM, what is normal for that distance of the rectus abdominis? So an abnormal diastasis is now looking to be defined as close to 3 centimetres. So one baby, 28 mils, and more than one baby at 3 centimetres. So interestingly, it's about clients' understanding of that. So a study in 2023 recruiting postpartum with a DRAM, 72 had to be excluded because they didn't meet that criteria. Another part of the debate is if we stop exercising to protect this natural diastasis process, are we creating more of a problem with abdominal weakness? What happens when the linea alba is not the anchor, and does our body adapt? And it's thought potentially yes, now that if this area, the linea alba, is thinned, potentially the rectus abdominis could be acting as a brace and needs to sustain its strength through pregnancy. The risk factors of developing a DRAM or a diastasis is, in fact, lack of physical activity before or during pregnancy. Weight gain too is a factor, multiple pregnancies, and also just laxity of tissue due to hormonal factors or other pathologies. But not so much more about lifting weights or too much exercise. So in summary, in regard to DRAM, the research shows no connection between coning and function. And it's important through pregnancy that all parts of the abdominal wall are strong and functional. And there's an aspect too that abdominal muscles are important and can affect that second stage of labour. As PIs, whenever we're doing exercise involving the abdominal wall, most important is ensuring breathing throughout, no breath holding, and an exhale connection with the core and floor. And let the client just take the lead on what feels right. Any concerns, refer on to the MO or a pelvic health physio.